Now I'm happy to introduce Dr. John Perlin, who is the president and CEO of the Joint Commission Enterprise. Dr. Perlin joined the Joint Commission on March 1st, 2022. Previously, as President, Clinical Operations and Chief Medical Officer of HCA Healthcare, Dr. Perlin led clinicians, data scientists, and researchers in developing a learning health system model for improving care at the system's 189 hospitals and 2,200 other locations. Before joining HCA, Dr. Perlin was under the Secretary for Health in the U.S. Department of Veteran Affairs, where he led the Veterans Health Administration to national prominence for clinical performance. He was also a Congressional Budget Office Health Advisor, and he has board service, including Columbia University's Health Policy and Management Program, Vanderbilt University School of Engineering, and he served as a trustee of Meharry Medical College for 15 years. So Dr. Perlin, so thrilled to have you here today, and I'm going to turn things over to you.
Well, thanks so much, Sue Ellen. And before we even begin, thanks to each and every one of you for your leadership in healthcare. I think for those of us who've been in healthcare for a while, I think you know that this is probably the most challenging time we've ever faced. And I think there are good reasons to believe this is the most challenging moment that healthcare has ever faced in its contemporary history. So thanks to each of you for everything that you do. This morning's topic is, of course, effective governance in its relationship to quality. And, you know, I just love working with boards. Boards are typically individuals who are there by choice, volunteering their time because they're absolutely passionate about the mission, about the service to community, et cetera. I think you've heard that I've had both the privilege of being on the management side, but also working on the governance side, and including as a member of the AHA's Board of Trustees, and culminating in chairmanship in 2015. It's an extraordinary privilege. Boards are an untapped resource. And the best of all worlds are when board, management, governance and management are really working together effectively in terms of helping the management team interpret the environment, appreciate the needs of communities, appreciate the resources as well as constraints, and together endorse a strategy that allows the safest, most effective, most efficient, most equitable, most compassionate care possible delivered in the highest value manner. That's service at its best. Unfortunately, there are data that say that's not how it always operates. In fact, the American Hospital Association, one of my former research fellows who gained some prominence recently as the White House COVID czar, Ashish Jha, surveyed hospitals, healthcare organizations, and found two things: that for too many boards, too many healthcare organizations, inadequate time was spent really talking about quality and performance. In fact, nearly a third of hospitals spent zero time having that conversation at their overall board level. And depending on the complexity of the system, there may be subordinate safety, quality, risk type committees, or there may be opportunities to address that at the overall board. But here's what we know, point two. The performance of organizations is directly correlated with the board engagement and knowledge and competencies in oversight of quality. Now, we all know that that is a fiduciary responsibility of a board member. But what you may not know is that the Centers for Medicare and Medicaid Services, CMS, feels so strongly about this that its QAPI guidance, quality assurance, performance improvement, was updated from 20 years ago this past spring. In March, they released new instructions that said that when accrediting organizations, be it the Joint Commission or state survey or anyone else, reviews, that there has to be evidence of board engagement in matters of quality. That engagement has to be demonstrated by specific products, a specific focus on areas of particular risk, a specific focus on areas of high volume. It didn't specify what the quantitative, ratio should be to the complexity of the organization, but they did say directly that the breadth of activity should represent the complexity of the organization that is being accredited. But even more importantly than that, a good, strong working relationship improves performance and is much more enjoyable. In my experience, whether it's on the management side or the governance side, I think the reality is we'd love to celebrate good things, but we know that bad things happen. And I think it's so important for management to be very transparent with board on matters of performance, because as things happen, some preventable, unfortunately, and others perhaps not. The first time that a weakness occurs shouldn't be or is known, shouldn't be at the time of a catastrophe. There should be a dialogue about understanding where there are areas of risk and a context for discussion that allows board and management to work effectively in mitigating whatever risk and obviously preventing recurrence of whatever happens. In fact, for those of you as board members who may have been around during Joint Commission surveys, one of the favorite questions that surveyors ask, encouraged by CMS, is, what is your engagement in board quality and safety and oversight? Have you been made aware of an adverse event? If so, how were you made aware? How did the organization address that? Are you aware of continuing activity?
You're muted, sir.
Sorry. At its best, the good board relationships really are one of the most enjoyable aspects of healthcare leadership. And it allows the full creativity of both governance and management to serve the needs of patients and communities as best they can. And that's really what today's discussion is all about. And we're fortunate to have a terrific expert in Dr. Kathryn Leonhardt. She's a physician and public health expert with over 30 years of experience in both public, private, and academic healthcare settings. She's researched, published, and taught in the areas of quality, patient safety, and patient experience. She's worked on specific research in quality for the Agency for Healthcare Research and Quality. Graduate of Williams College, undergraduate medical degree from University of Michigan, and her Master of Public Health and Epidemiology from Cal Berkeley. She's been sought to speak and lead and train in governance as it relates to quality and performance internationally. So without further ado, the person who leads our international quality education is our principal consultant, Dr. Kathryn Leonhardt. Thank you again for all that you do in support of healthcare. And we know that you want exactly what I want for myself, for my family, for my community: safe, effective, efficient, equitable, compassionate healthcare in a context that doesn't require an advocate, a system that's highly reliable. Kathy, let me turn to you and I'll sign off. Thanks.
Thanks for that nice introduction, and good morning all. What a great pleasure to be with you today to talk about this really important topic around leadership. Leadership matters. When we talk about quality and safety, we know that at every level of the organization, we have responsibilities, from the frontline staff up to the leadership of the hospital, even outside the doors of the facility. Stakeholders such as government agencies, accrediting organizations like Joint Commission, professional groups like the American Hospital Association, and our patients and communities. So I want to focus on that critical leadership level, the governing body, the governance, board of directors, trustees, whatever name you use for your organizational governance structure. I want to share some information and proven practices and how you can maximize the potential for your governance to fulfill that critical role of effectively overseeing quality and safety within your hospital, to help guide performance of your organization to fulfill those goals around quality and safety. So maybe you are part of a really effective governing body right now, or you've worked with one in the past, that they're doing a great job overseeing quality. So when I talk to leaders, CEOs, C-suites, board of directors around the globe, I asked, how do you describe that really effective board? What are the characteristics or actions that provide you the confidence that you're doing the work you need to do? Well, I get feedback like board members ask the right questions when they're really engaged, or they're very knowledgeable, they're empathic. So let's use this framework to walk through, gain some insights, some recommendations, review some proven practices for each of these 6 steps to help you create a truly effective governing body that you're confident that you're able to fulfill your role if you're one of those board members, or as a senior leader, you're comfortable with your governing body that will help maximize their potential to move forward on this journey we're all on for quality and safety. So there's a lot of attention today, actually, on the roles and responsibility of the governing body. This case study provides us an example of our current state, right? How the role of the governing body is being evaluated by CMS, by Joint Commission, as we look into our quality and safety programs. So here's an example from this year. This is from a hospital that had 2 adverse events related to maternal hemorrhage on their labor and delivery in the year 2023. They occurred within 4 months of each other. Well, when the meeting minutes from the governing body were reviewed, there was no documentation from the entire year, all the way through October, that these events had been reviewed by the governing body. And in fact, when they looked at the Quality Assessment and Performance Improvement, the QAPI program meeting minutes, they identified that indeed, with the first event, some corrective actions had been identified, including putting a postpartum hemorrhage kit and medication kit on the labor and delivery unit. However, 9 months later, they had not been put in place. And in discussions with the leadership of labor and delivery, they noted that they had insufficient resources to implement this improvement effort. In another review of the governing body meeting minutes from this past year, it indicated that no resources had been allocated to labor and delivery for their quality improvement projects. So in summary, this case study shows us that the governing body in this hospital was not demonstrating that effective oversight of quality and safety. Well, unfortunately, we see around the globe this continuing challenge of dealing with patient safety events. In fact, there's been some recent publications last year and this year that shows us we haven't made a lot of improvements since the Sentinel article "To Err is Human" was published in 1999. In fact, we had a repeat of that study that was published by Bates in New England Journal of Medicine beginning of this year in January that showed we have about the same rate. 1 in 4 hospital admissions have an adverse event. And unfortunately, with our pandemic, we saw an increase in some of our hospital-acquired conditions, CLABSIs and CAUDIs. Since the pandemic, they're starting to return. We're starting to get control on things, but we're still struggling with quality and safety. And this data from Joint Commission shows that that lack of the governing body, board of directors, and effectively overseeing quality and safety is pervasive. In the year 2022, as you see on this slide, in our over 40% of hospitals that were surveyed by Joint Commission had citations in their leadership chapter. That's the section that evaluates how the leadership, including the governing body, fulfills their expected performance roles. The third most frequently cited standard of this leadership chapter is around the standard that describes the governing body as ultimately responsible for safety and quality of care, treatment, and services. We found in the year 2022 that we're continuing to have challenges, just like in that case study, where the governing body is not fulfilling their role to oversee quality and safety within the organization that they govern. So why all this emphasis? We understand we're struggling with safety. We understand our governing body is maybe challenged with fulfilling their role. What does it matter? Well, it matters because the data shows us that when boards take their responsibility seriously, when they implement that responsibility for being accountable for quality and safety through actions such as prioritizing quality in their top priority of the organization, spending sufficient time on the agenda to discuss quality and safety, monitoring those quality metrics to identify how the organization is performing, and building that trust that Dr. Perlin referred to, that relationship between the governing body, the leadership, the medical staff, in fact, all of the staff. When a board of directors takes those actions, the research shows us that there are better outcomes for the organization. In fact, there's better performance in selected clinical quality metrics. There's lower mortality rates, and the quality improvement program themselves perform better. So the evidence suggests that the governing body plays a critical role in driving quality and safety outcomes in our organizations. Well, these ongoing challenges in quality and safety has led to a call to action across the globe. The World Health Organization published in 2021 their Global Patient Safety Action Plan, providing strategic direction with concrete actions to be taken by countries, by organizations, healthcare facilities, even by themselves, the World Health Organization. I'm going to take a pause because I've lost my sharing of my screen. I'm going to go back to that. I'm going to ask Sue Ellen, is it still being shown?
No, I can't see them, and I could not see you advancing your slides either, Kathy. So I'm going to ask the team to figure it out.
So I'm going to ask, is my slide showing now on government impact?
Yes.
Governance impact?
Yes,
Yep.
it's slide
Yes.
5.
Okay, great. So apologize. I'm going to, I will make sure that a copy of these slides is shared with all as I'm walking through that. I'm not sure the technical issues that they're not coming through. So we're talking about the call to action that has come in to play across the globe around how do we address these challenges with quality, safety, and the role of the governing body, right? So the World Health Organization has published a call to action in their Global Patient Safety Action Plan. The United States in 2020 published Safer Together, a set of goals for safety, a national action plan for us. The National Quality Program published a call to responsibility for the governing body. And in September of this year, the President's Council of Advisors on Science and Technology sent a letter to the President asking for a transformational effort to address patient safety. What's important in each of these calls to action is that they highlight the role of the governing body, the critical need to recognize that the governing body is accountable for overseeing quality and safety. So hospitals are struggling. We're struggling with safety and quality. We're struggling with how do we put in place these evidence-based roles of the governing body. But our data shows us through Joint Commission surveys and CMS, Centers for Medicare and Medicaid Services surveys, that governance is not being effective in this role. Well, the challenge we have, as those of you who are board members, those of you who are leaders, is it's really not well defined anywhere in terms of what is the true responsibility and role of the governing body. There's no evidence-based model, no framework, no roadmap for how our governing bodies should perform their duties. There's a gap in the literature for specific processes, details that can help governing bodies enact their key tasks and achieve those goals. So we need a standardized approach with detailed guidance on who should be on the governing body, what they should know, and how they should perform their job. So we're going to follow these 6 steps, and I'm going to share some proven practices for each of these steps as a start of a roadmap that you can take and build on to develop your effective governing body. Now, we know the first step of anything we do, whether you're trying to improve your organization, whether you're trying to improve your own personal performance, be it running a marathon or losing weight, is to do an assessment. Determine what is your current state. And this assessment is really important to gain insight in how is your board performing now. So I want to ask you to take a moment and reflect on this. Think about, how is your board performing? What best describes your current performance of your governing body? Does your board focus primarily on its quality efforts by looking at regulatory requirements? Or does your board hear a report from a subcommittee, maybe the quality committee of the board? But that's the primary effort when you talk about the board activity and focus on quality and safety. Or does your board actively participate in developing the quality plan every year, setting quality goals, reviewing progress, even reviewing safety events like we heard about in that case study? Where is your board? How would you assess your current board? Well, for years, the Joint Commission has been working with leadership teams, with healthcare systems across the globe. And the data you see here on this slide comes from 10 years of assessing boards, determining how mature they are on their journey towards high reliability, using the 4 categories of beginning, developing, advancing, and approaching. Organizations have conducted a self-assessment, and we've collated this data to evaluate where boards are on that maturity level. Well, this 10 years of aggregated data shows that the majority of boards, about 55%, are limited to that hearing reports, gathering information, not active engagement, hearing reports from a quality committee. So we put that in the developing category, not actively participating in setting plans or reviewing detailed patient safety events. So based on our Joint Commission data, we've got some opportunities to improve, to develop a more mature board, to utilize the expertise that's on our governing bodies to help drive quality and safety in our hospitals. So how do we do these assessments? Well, there are a variety of tools out there available for you. There's no standard tool, and we encourage you to look through some of these examples and select the one that is best for your organizations. Some of them come from government agencies like the National Action Plan, as you see down on the lower left, that self-assessment tool. Some come from organizations like American Hospital Association at the top right, or IHI on the lower right. And of course, our Joint Commission ORO, a self-assessment, which focuses on high reliability. It's interesting that the role of the board is really about evaluating performance of an organization, right? Overseeing, evaluating, monitoring. Yet many boards don't use that same approach to themselves. American Hospital Association, on its annual survey of governing bodies, last year identified that 27% of the respondents did not use any type of assessment of their board. Assessment should be broad. Assessment should include evaluating the members of the board chair. Do they meet a selection criteria? Are they participating as you want them to? Evaluating the effectiveness of meetings. Even identifying, does your board meet those required elements? Are they effective in achieving the goals of the organization? So I ask you, do you do an assessment of your board every year? Pick one of these tools, or maybe you're aware of another one, and use it to identify where your board is on this journey of becoming an effective governing entity. So once you've assessed your board, identified your strengths and your opportunities, you need to be sure you have the right people on board. Well, we know healthcare is an incredibly complex industry, and it requires a very diverse set of expertise. But it's not clear what the right mix is. There is no established standard for who should be on your board. Again, in last year's AHA survey, these were the top 5 criteria for selection of board members on the right side in this slide. The knowledge and skills and behaviors that were shared by the survey respondents. And we see that financial background was the most frequently used criteria for selecting board members. And then strategic orientation. And we go all the way down to quality and patient safety, which was the least noted criteria for selecting new board members. On the left side of this slide, we see a pie chart. And this comes from an article that was recently published, which is a survey of the top 20 hospital systems in the United States, identifying what are the board member professional backgrounds of these top 20 health systems. And we found that of those systems, over 56% of the board members had a financial background, and only 15% had a clinical or health sector background. So my question is, do you have the right board member diversity, participation? Do you have board members that have the knowledge, skills, and competencies to fulfill the functions and responsibilities of overseeing quality and safety? I think this is a challenge for all of us as we're trying to identify, as we navigate through this complex healthcare system, who should be on our board and what skill set should they have? Well, a proven practice is including a patient on your board. This slide represents information from the World Health Organization Global Patient Safety Action Plan, which was published again in 2021, highlighting that role of patient and family engagement, hearing the voice of the patient at your board level. Well, unfortunately, as the WHO is doing some monitoring and identifying countries and organizations, how they've implemented the Global Safety Action Plan, this year, only 13% of countries that responded to their update survey have a patient representative on their governing body. So we still have some ways to go. I ask you, do you have the voice of the patient at the table? Have you added that representative to your governing body? So once you have the right members, now you need to make sure they have the right knowledge and skill set to fulfill this responsibility. Unfortunately, studies have shown us that board members are not receiving education. In fact, 2/3 of boards don't have any continuing education requirements at all. And our board members have shared in different studies that many of them are not confident that they have that knowledge, that ability to understand what is quality, what is safety, how are they supposed to fulfill their responsibilities in overseeing this important work. So there are various resources available for governing bodies, board members, to receive that education. I'm excited to show this slide as it's a snapshot of a new Board Education Resource Center that's now available on the Joint Commission Resources webpage. We just started this webpage this summer, recognizing the need for additional resources for board members to gain this information, obtain some new knowledge, understand why the role of the board is so important in quality and safety. On this webpage, you can go to 4 categories of information. The first category is what the board needs to know, basic information and educational resources around quality, safety. What does CMS mean? Who is the Joint Commission? We also have a section on why the board needs to be involved, details around the requirements from CMS, the standards that the Joint Commission has that hospitals are expected to meet. We also recognize that it's a very confusing process to be a governing body as it relates to quality and safety. So we provide some tools and templates, some examples that the boards can use to fulfill this responsibility. And our 4th section is really exciting. It's a leading practices section where we have video clips, where we've interviewed leaders, CEOs, board members, chairmen of the boards, where they've shared how they've implemented innovative ways to engage their board members and maximize the expertise of those governing body members. So this list provides just an example of the minimum content that board members should have, the knowledge and information that they should be familiar with to fulfill that role of overseeing quality and safety. This comes from our new Board Education Resource Center and provides some of that background on some of the information you see here. But we also see the method of learning can be different. We see boards that use some type of education activity at every meeting. It may be an article that's read or a short presentation that they hear. So boards are continuously learning at every meeting. There can be readings, articles that are shared amongst the board members. I'm going to pause and ask that everyone put their phone on mute, their computer on mute. Thanks so much. But we also see board members that take a weekend and go on a retreat, focus totally on quality and safety. In fact, I encourage you to go to the website, listen to one of the leading practices and the innovative approach that they've developed in their organization called an immersion program, where they actually take their board members, bring them within the hospital units, spend a half a day in the emergency department to truly understand what and how the staff do their work, some of the challenges they're faced with when we talk about quality and safety. And they take that experience back to their next board meeting and discuss how they can be more effective in supporting the staff and fulfilling their roles around quality and safety. Right? On the right side, you see a cover of a new book that just was published by Joint Commission Resources. I encourage you to look this up. It's a great tool that your board can use as a foundational information, again, basic knowledge and information on what is quality, safety, in the Joint Commission, and provide some innovative, provocative questions that the board may want to ask to learn more about quality and safety, to understand how they can be more supportive of the leaders and the staff as they're trying to push through their initiatives around quality and safety. So we reviewed those first 3 steps, really focused on the prerequisites of developing the board, assessing your current state with some type of self-assessment, self-evaluation tool, selecting the right members for your governing body, and then providing the necessary education and resources so they have the knowledge and capabilities to fulfill their responsibilities. The next 3 steps are really how the board performs those responsibilities. So let's reflect again on your current state. How much time does your board, does your governing body spend during each meeting on the topic of quality and safety? Is it 40%, 30%, 10% of the board time? spent on quality and safety? And for extra credit, what is the right amount to spend, especially when the boards on average meet about 20 hours per year? Well, we've seen, based on the literature and studies that have been done, that 93% of boards have on the agenda and discuss finance on every agenda. And only about a third do not have quality on every agenda. And over half spend less than 20% of their time on quality. Yet the literature tells us that when boards spend more than 25% of their time on quality, they have better outcomes. So we're challenged here. We know that the more time, the more effort those engaged, actively engaged boards spend on quality and safety, we have better outcomes. But our information is not aligned with those best practices. So I encourage you to look at your agenda for your board meetings. Agendas are a very effective project management tool. A really good agenda for a governing body can assure that the board meets their required responsibilities by putting it on the agenda. And it also sets the board framework for its approach to quality and safety. This is an example agenda, again, available through our Board Education Resource Center. These are complementary materials, by the way. And it's important that you identify what should be on your agenda, starting with that patient story to humanize this information around quality and safety and the metrics that can be overwhelming and confusing for many members of the board. But hearing from a patient or hearing the story of the patient can help humanize this information. And making sure you include those quality performance indicators that meet the Joint Commission requirements, that may meet the CMS requirements, and you spend the necessary time to review those things, right? So identifying the key items, allotting the appropriate time to discuss them will help you set that framework for your board as it's addressing quality and safety. Allows them to fulfill that role of overseeing. And in addition to the agenda, I encourage you to look at an annual schedule. Defining the frequency of review of these measures and activities will help assure compliance as well as develop that roadmap for the board. And this is just a very simple example that identifies over the course of the year what one board selected to review at each of their meetings to assure they covered the broad spectrum of quality and safety requirements. So use these tools to set your agenda, to set your roadmap for the board. So let's dive deeper now into that core activity of the board, that overseeing quality, because that's a really complex activity and there's a lot in it. But one of the first sections, the first steps you need to do in this overseeing quality is define what is quality in your organization. Quality is actually a very challenging concept, and it's not standardized across the globe. What's really missing is specificity. So the example I have on this slide comes from the 6 dimensions of quality that were referenced initially in the initial Crossing the Quality Chasm, was updated in the updated version, Crossing the Global Quality Chasm from 2018, and actually includes a 7th dimension, integration, which the World Health Organization added a couple of years ago. So when you define your quality framework, be specific, understand the complexity of quality includes all 7 of these dimensions. Now, there are other options for framework. You don't need to use the 6 or 7 dimensions of quality. You may use the framework of structure, process, outcome, or you may define your quality framework by the clinical care and services that you deliver: pediatrics, women's health, surgery. What's important is you, as part of the governing entity, as part of the leadership team, need to define what is your quality framework. You need to set clear priorities so the staff can operationalize them. You need to define what measures you will use in this framework to monitor that the governing body can use to oversee that performance. And you need to hold leaders accountable for performance. Now, quality is ever evolving. We are focusing on many of the social issues that are challenging to us that became even more transparent during the pandemic, such as equity and environmental sustainability. So this requires that the governing entity review this framework on a regular basis. Select the framework, select the metrics that make sense to your organization, to the communities that you serve. So defining accountability is a critical section. It needs to be clear at all levels of the organization. What are the accountability? What are the requirements for all staff? This is an example from the Joint Commission requirements. Our standards specify very clearly responsibilities of governance. We recognize the difference between governing and managing, between the governing body and the CEO and the hospital leadership. But we set out very clear requirements, very specific around what the governing body is responsible for, what the leadership team is responsible for, what all staff are responsible for as it relates to quality and safety. It's really important that the more specific you are in setting your accountability, the more likely that individual, that group will be able to perform the tasks. And the more alignment you have, the more your efforts are aligned, the better chance you're going to be able to achieve your desired outcomes. So setting your framework, defining accountability, being very specific is one of the ways that we can achieve our goals in quality and safety. Now, another resource we have to help us define our accountability is CMS, Centers for Medicare and Medicaid Services, our federal government agency that helps define this role of governing body and its responsibility for overseeing quality. In fact, CMS very specifically says that the governing body and leadership must be engaged, actively engaged in the oversight of quality. The role of the board is beyond receiving a report. In fact, the board has responsibilities both for oversight and some decision making. There are very specific responsibilities that CMS identifies in their QAPI, Quality Assessment and Performance Improvement Project, for the board. It requires that the board specifies the frequency and detail of data collection, the data used to monitor effectiveness and safety of services and quality of care. The board needs to help determine the number and type of annual projects that are done for performance improvement. The board needs to review the results of the QAPI data collection and make decisions based on that review. The board, the governing entity, should be reviewing adverse patient safety events, how they're measured, analyzed, and tracked. And surveyors are confirming this active engagement through review of meeting minutes, even attendance rosters, as we saw in our case study. That was a real case study reported through CMS. So clearly, the governing body is being recognized, and those clear responsibilities can help drive improvements. Your responsibility is to know what your accountability is and be able to enact it in very specific tasks. So we know for you as a governing body to effectively oversee quality, you have to define that quality framework, set priorities, assign accountabilities. And we all know in the world of quality that we need data to monitor performance. So data dashboards are a frequently used tool, often shown to governing bodies. But there's a wide variation in these dashboards, what's on them, where they get reported. Some of the challenges we've seen with dashboards and the role of using them with our governing boards is that sometimes the data is limited. Maybe these dashboards are not fully transparent. Sometimes there's too much data, and this leads to maybe governing bodies who haven't been educated and oriented to what's on them being intimidated or overwhelmed, unable to be actively engaged. Sometimes the data only focuses on those required measures, maybe regulatory accreditation measures, and not truly focusing on what's important to the organization. And often we don't have enough time on the agenda to discuss all this. Yet we know from research that there are better quality outcomes in organizations where the board receives a formal quality performance measured report. So this example on this slide comes from Johns Hopkins Medicine, where they've developed a consolidated quality performance statement. This was reported a few years ago in our Joint Commission Journal on Quality and Safety. But what's key in this is what they've included on their report. Number one, it represents all entities across the system. It includes measures that reflect what is important to the organization. It may include some required reported measures, but it also is based on their risk assessment of what measures are most important to our organization. Risk to patients, risk to their reputation, risk to their financial health. They've grouped their measures into categories, focusing on patient experience, harm, and efficiency. They've set a frequency of reporting. They report these measures 4 times to their quality committee. They have validated the data to assure that it's accurate. And they have clearly defined accountability for each of these measures, including how they respond if an entity does not meet their target. Governance needs to be able to understand quality data. This is an example, a way for organizations to share with a governing entity. I want you to reflect on your own board and your role if you're a board member. Could you read this report? Would you know what types of questions to ask? Does this show, would you be able to ask, is this improving or getting worse? How do we compare to others? Has this been validated? How can we identify opportunities for improvement? Board members need to have less reporting and more engagement. So when we talk about culture, I frequently describe the relationship between leadership and culture as 2 sides of the same coins. We know that leaders establish and influence culture by various means. So let's reflect back on that case study as we talk about culture and the role of the governing body in creating that culture of quality and safety. One of the actions that the governing body needs to do is setting the vision, creating clear goals and expectations. Perhaps it's zero harm. Imagine in that case study, if the governing body had said zero harm is our goal, would that second event have occurred, or could it have been prevented by some of the interventions that had not been put in place? Providing the necessary resources is part of leadership responsibility. Making sure they have the resources, including human resources who are trained and educated. Think about that case study. What if the board had provided the necessary resources to purchase the postpartum hemorrhage kit and the medications after the first event? Defining behaviors and codes of conduct and role modeling those. Imagine in that case study, if the board had done an assessment the prior year and recognized in their own board meetings that they were not reviewing patient safety events on a regular basis? What if they had changed their agenda to make sure those reports got to them when they occurred? Would that second event have happened? And how about engaging staff? Some of those strategies like leadership rounding. What if the board had spent some time on labor and delivery, had listened to staff around some of their challenges, maybe had talked to some of the patients there? Would there be that second event? Moment to reflect. How is your governing body supporting that culture of quality and safety at your organization? Well, I've reviewed some of these 6 steps towards building a more effective governing body. We've identified some proven practices, some resources that help you address the challenges that we face in healthcare today. I encourage you to take these 6 actions back to your board. Consider this opportunity to start building a framework for a more effective governing structure that can actively be engaged in overseeing quality and safety. I thank you for your time, and I'll turn it over to Sue Ellen for some questions. Thanks a lot.
Great. Thank you, Kathy. We really appreciate you and Dr. Perlin being with us today. If you do have questions, please place them in the chat, and I'm actually going to start them. To fulfill the requirement of evidence of board engagement, it seems that board members need to have some knowledge of quality. In my experience, most board members don't believe they have the expertise to be engaged. Do you have any suggestions regarding board education on quality and patient safety?
Yeah, great question. Thanks so much. Yes, I do. I would encourage you, number one, to go to the Joint Commission Resources Board Education Resource Center, and there is a start of information around education. I will also refer you to the American Hospital Association website, where there is a huge volume of information. I'm working with Sue Ellen and her team and just amazed at the information that's out there. I think what's most important is you work with your team, your governing entity, and your leadership around what are the key core elements that you feel your organization should be learning about. Again, do your self-assessment, identify where those gaps in information. Are you struggling with understanding quality metrics, or is it basics of quality? Is it even what is Joint Commission? So you need to do that assessment, and I think it's a really helpful approach to not overwhelm the board with a lot of information right at first, but to create a schedule over the course of the year of how you might gain some knowledge, maybe during each meeting, little snippets of information as you go through the year.
Thank you, Kathy. Next question. In a large matrixed organization, how should a system level board oversee delegated quality compliance to local hospital boards? That's a really great question.
That is a great question, and honestly, one that we see organizations struggling with. There is some guidance and flexibility that's defined within the CMS QAPI COPs, so I refer you back to those to make sure you're meeting the CMS requirements. I've seen different structures all around the globe, unfortunately. This is where we do have a gap in our evidence in terms of understanding what is most effective. I've seen organizations where it goes up to a system committee and all the quality is discussed up at the system. I've also seen organizations where they have kind of the separate entities have their own governing structure that reviews their quality and safety. I think there's lots of models out there. It's finding one that works best with yours. We've talked about it, Joint Commission, identifying a couple best practices, leading practices, I want to say, and anticipate that we'll be sharing those on our board resource center as we continue to update the information that's available.
Thank you, Kathy. The next question, there is often a hesitancy to document too much in the minutes for adverse events due to potential litigation. What or how much is acceptable? I've also seen minutes that have no detail and attach reports. Is that acceptable as long as the report is referenced? Understanding that if there is action taken, it should be documented in the minutes. Another great question.
Yeah, great question. Thanks so much. You know, that is a question that has a lot of factors that will impact that, depending on your state and your state laws and how you've defined quality protected documents. So I would have to defer you back to, you know, the understanding what your state regulations are in terms of protected documentation. I think what's important as it relates to, say, CMS and Joint Commission in this, and it's even beyond that. I always like to go beyond the rules and regulations. What makes the most sense for an organization? It is at least identifying in your meeting minutes that you have reviewed and discussed quality safety events and you're using the data to make decisions, right? And having some documentation that demonstrates that you are actively engaged. Not having anything in the minutes, we know what's if it's not documented, it didn't happen, is an opportunity to be, again, I hate to go back to CMS and Joint Commission, but there's that chance you could be cited on that. So I encourage you to find a way, working with your maybe your legal team, but making sure whatever confidential patient information is protected, but having some documentation that assures you have reviewed it, you've understood it as a board member, and you've taken the appropriate action. I go back to that case study. There's no documentation that patient safety events were even reviewed, let alone resources allocated in response to that event. The difference between quality assurance and quality improvement, between the old approach in CMS 20 years ago and our current approach, is that you need to identify you're doing something in follow-up. There's evidence that you are following up, that actions have been taken, that you're monitoring the response of those interventions to show that you actually have improved things. You've reduced the risk of harm if it's a safety event. So that's that kind of last step is what is really important.
We are at the top of the hour, but Kathy, I'm going to ask if we can continue for 5 more minutes to get through a few other questions. And for those of you that can stay on and join us, that's great. If not, you can listen to the recording. The next is more of a comment. Since the business of a hospital is providing safe and quality patient care, clinical professionals need to be members of a board to even understand the issues and challenges of patient care. And there's 3 thumbs up, so a lot of folks agree with that. Do you just want to comment on that quickly, Kathy?
Yeah, make sure I understand the statement. It's just recognizing the need for clinical backgrounds on your board. Yes, I do agree with that. Again, healthcare is complex. It's very complex. So even if you're a non-medical person and go through education and training, have great orientation on your board, there's some depth and understanding that clinical people or people with a healthcare background have through their years of education and experience. And I think it adds a voice that is really important. Who that is needs to be determined, whether it needs to be a physician, a nurse, a pharmacist, a PT, and what they're representing. I think it's really important that we are really clear when you're on a board and you're a physician that what is your role? What is your role there? Is it just to talk about the medical staff issues? Or is it to talk about the clinical issues as a physician may understand them differently? So just having a clinical person on the board may not fulfill the role that all of us think about. Sometimes we come to boards with our own agenda, and I think that's part of defining the roles and accountability of each of the board members, honestly. So yeah, I do believe it's important. I think that we have some gaps in understanding of, again, what is that mix? Should there be 1 doctor, 1 nurse? Should there be 3 nurses and no doctors? I don't think we have any evidence that tells us exactly what the perfect mix is. I think I just look at the complexity of healthcare and who are the right people to be at the table to help us.
Thank you, Kathy. The next comment and somewhat of a question, driving quality through your quality committee always allows for robust discussions. Adding non-healthcare members can be valuable. Specifically, finding community members that lead an organization or quality department in the food industry or manufacturing industry brings a high level of expertise. They use many of the same standards and tools and are heavily based on quality. They will quickly pull away from individual perspectives and introspective questions around the process. So I think that was more of just a comment, but I think the person is definitely right there.
Yeah. We've learned a lot from non-healthcare industries. We talk about high reliability and what we've learned from aviation and nuclear power. But I think we're all recognizing that there's multiple industries and disciplines and professions can add to the richness of healthcare. As we're in a very digitally driven field now, I think it's really great to include some of the technology expertise, certainly engineering, as we've learned through our human factors and systems thinking is really important. So we strongly encourage that diverse expertise that can add to a better understanding of how to run an effective, high quality, safe organization. I will reference again, the Board Education Resource Center and our leading practices. There's a great story on one of our shared participants talks about the board going to a manufacturing company of one of the board members and learning how quality and safety is addressed in a non-healthcare setting. So it's a great example of that, exactly what the participant shared. Lots of rich information we can learn from each other.
All right, Kathy, I want to thank you and Dr. Perlin for joining the AHA today on this really important topic.